We're not quite at the point where we can image dementia itself, in other words, the function of brain, but what, of course, we look at is the structure that is associated with conditions that are dementing. If you look at Harrison's textbook, there's something like 75 categories of dementing disorders. Just about anything that disrupts brain function may be associated with dementia. So what I'd like to do is talk to you about the kind of things that we're likely to run into on a daily basis and perhaps on a monthly basis. These are the conditions that cover the vast majority of dementing disorders that we're going to see. One of them is the most common dementing disorder, that's Alzheimer's disease. I'll spend a little bit of time on that. Vascular dementia is the next category. When you combine Alzheimer's disease and the vascular dementias, you wind up basically covering the vast majority of the dementing disorders that we're likely to see. There are inflammatory conditions such as CJD and the so-called treatable, potentially treatable dementia, which is not really a dementia, and that is hydrocephalus or normal pressure hydrocephalus. So these are the things that I would like to cover with you. In order to understand pathologic aging, which is really what Alzheimer's disease is, we have to have some concept of what normal aging is. Now, you've seen the scans of people throughout the lifespan, and if you try to tabulate and quantify things like ventricular and sulcal size, you find that things over the normal lifespan up to something like 60 or 65 years of age remain pretty stable. And then after that, in normal individuals, and this is a cross-sectional study, this is not a longitudinal study, after the age of 65, you begin to see an accelerating increase in the volume of the subarachnoid spaces. And that volume seems to involve the cortical surfaces more than the ventricles. There's an acceleration in the size of the subarachnoid spaces. Now, if you look at an older individual, let's say somebody over the age of 60, 65, who looks like a youngster, the ventricles are small, the sulci are small, the transverse fissures, which I'll talk to you about, are not enlarged. In other words, there's no evidence to speak of hippocampal atrophy. This is an example of so-called successful aging. And the specificity of this finding is very high. In other words, if you see somebody that looks like a normal brain in an older individual, the likelihood that this person has structural damage is quite low. Well, then, so if you have a patient who is demented but has a normal-looking brain, you think of something like pseudo-dementia. In other words, dementia related to depression or possibly related to some kind of drug interaction. The problem arises when we see an older brain and the ventricles are a little big. The one on the left, the ventricles are a little bit big, the sulci are moderately enlarged. On the one on the right, they're a little bit bigger. What do you do with this? There's a wide range of normals, and what do we do to evaluate this? Now, in studying Alzheimer's disease at the Aging and Dementia program, we decided to try to address the question from the point of view of a radiologic pathologic correlation. That's always the best and most convincing paradigm for establishing radiologic findings. So on the next slide, first of all, let me review what Alzheimer's disease is. It's been called the disease of the century. It's, as you know, a staggering medical and social problem, the fourth cause of mortality after heart disease, cancer, cerebrovascular disease. More than 1 million people in nursing homes, 5% of people over the age of 65 and 20% of people over the age of 80 are supposed to have this dementing disorder. The neuropathology was described by Alois Alzheimer in 1907. Previously, it was described in the French literature back in 1838. And what are the pathologic features? Neuritic plaques with a central core of amyloid. So amyloid is very important. There are paired helical filaments known as neurofibrillary tangles. They're granulovacuolar bodies. Do we see any of this? Not at this point in time. There was a lot of literature, early literature, when we became able to look at the brain in cross-sectional planes through CT scanning. There was a lot of literature describing big ventricles, big sulci, contradictory reports saying, well, big ventricles don't mean anything, it's really the sulci that are important, and so forth and so on. So this is our first radiologic pathologic correlation in which we tried to get to the bottom of the question, what are we going to see in the imaging of an Alzheimer patient with dementia due to Alzheimer's disease? This is the pre-mortem scan of a patient in her 70s who's very advanced. It's very hard actually to scan somebody who has advanced dementia. Usually you're going to scan somebody who has something like moderate dementia. And the interesting thing in this patient who's advanced in her dementia was no longer able to speak. She only makes sounds, totally incoherent. The kind of shocking thing, so to speak, is that the ventricles and the sulci at the supratentorial level are not really all that big, are they? But when you look down at the temporal lobe, you see that there is considerable temporal lobe atrophy. The fissures are big, the transverse fissure is big, the temporal horn is big. And this is really what is pretty much the consensus today of how Alzheimer's disease progresses. It starts in the temporal lobe, it starts in the hippocampus, and then progresses on to the parietal lobe, and after that becomes a generalized atrophy. So what we see are the structural consequences of the pathology. So if you have an advanced Alzheimer patient, this is what you're going to see. You're going to see a marked enlargement of the transverse fissures on cross-sectional imaging. The temporal horns become large. The space between the transverse fissure and the temporal horn is what's left of the hippocampus. The hippocampus is a kind of a sausage-like structure that winds around from the uncus area back and merges eventually with the fornices, and then eventually ends at the level of the mammillary bodies. This is what you're going to see pathologically on a coronal plane. The patient on your left is a non-Alzheimer patient with dementia, happens to be a Parkinson's patient. You see a robust hippocampus, a robust parahippocampal gyrus. On the Alzheimer patient on your right, you see there's a shrinkage of the hippocampus, and even more dramatically, in this particular case, the parahippocampal gyrus is markedly shrunken. What has happened because of this shrinkage? The temporal horn has enlarged to some degree compared to the relatively normal one on your left, but look at this transverse fissure. This huge enlargement of the transverse fissure as a secondary consequence of the atrophy. And there's two claws, actually, that are formed by the transverse fissure, or the choroidal hippocampal fissure, if you wish. And that's the choroidal and the hippocampal branches or claws that come out of the transverse fissure. So this is what you're going to see. The typical MRI features of AD are really, of Alzheimer's disease, are really no different than that original CAT scan that I showed you of that unfortunate patient. What you see on your left is the characteristic atrophy of the temporal lobes. Notice that the left one has a lot more atrophy than the right in this particular case. It may be the left, it may be the right. It's very often asymmetrical. It may or may not be symmetrical. And when you get higher up towards the level of the ventricular bodies, you notice that there isn't all that much atrophy. It just looks like any other older individual with so-called age-related volume loss. So what you can actually do is you can create a template of the characteristic size or the median size and configuration of the hippocampi shown here in cross-section on a patient with very minimal cognitive impairment. That's not considered dementia, so-called mild cognitive impairment, or MCI, though there's a risk for developing dementia on follow-up studies. This is what you see in the typical MCI patient. So anteriorly, you're at the amygdaloid nuclei. You get back into the head and body and tail of the hippocampus. And then progressively, if you're looking at mild dementia patients, it's a mild Alzheimer template, a moderate Alzheimer patient, and the typical advanced Alzheimer patient, of which there are very few. You notice a progressive atrophy of the hippocampus at all levels, the body, the tail, all the way through, And correspondingly, the transverse fissures are enlarging, and even the temporal horn is enlarging. If you look at a sagittal plane, you can see the gray matter of the hippocampus. You can see that claw-like structure that I described to you. Nestled in between is the head of the hippocampus. Now, why don't we use the sagittal? Well, the problem, of course, is the partial volume effects of slicing an elongated structure in the sagittal plane. So you're never quite sure, am I in the hippocampus itself, or I'm just looking at partial volume effects? So look at what happens to the transverse fissure. It becomes quite enlarged. And then this communicates with the retropulvinar cistern. This same fissure goes to the back of the thalamus. And here's an advanced Alzheimer patient at pathology showing this is a very advanced degree of atrophy. This is not likely something you're going to see on an imaging scan because the patient is not cooperative enough to be scanned. You notice the shrunken hippocampus, the parahippocampal gyrus, and the rest of the temporal lobe gyri are mere slivers. And then the disease has progressed into the parietal phase, and from there on to the rest of the brain. Now, there's another pattern of atrophy, frontal and temporal lobe atrophy, which characterizes so-called frontotemporal dementia. Now, strictly speaking, though there's some controversy about that, that is not Alzheimer's disease. And it's not necessarily Pick disease, but there is a subgroup of the frontotemporal dementia that is due to Pick disease, a very rare dementing disorder. How about special studies? Well, PET scanning, which has recently been approved by Medicare for reimbursement in the evaluation of Alzheimer's disease, though with some, I understand, fairly severe restrictions on who gets scanned and who doesn't get scanned. PET scanning and the so-called poor man's scan, or the SPECT scan, the perfusion scan with radionuclide, will show you a certain pattern which corresponds to the structural damage. Characteristically, you will see severe depression of temporal lobe metabolism if you're using FDG or another glucose analog with PET scanning, or at SPECT scanning, you're going to see a marked decrease in perfusion and metabolism of the temporal lobes. Notice this is reversed, this is left, and this is right. Notice again in this patient, it's the left side that's markedly involved. The right side is also involved. On the coronal view, you can see that there's been extent of the changes to the parietal parenchyma, more so on the left side than on the right. And these are corresponding cross-sectional images. Can we use the other SPECT, proton spectroscopy, the newer SPECT? Well, there is a characteristic myoinositol peak that's been described in Alzheimer patients. There's a decrement in the NAA peak, as you might expect, since there's decreased neuronal activity. Myoinositol is not pathognomonic. It's described in a number of conditions, but it's one of the findings that can be seen with Alzheimer's disease. Now, here's something that's caught everybody's attention recently. We'll go from structural degenerative changes to an inflammatory process known as CJD. And the characteristic features in Jakob-Creutzfeldt or Creutzfeldt-Jakob disease, as it has been rearranged, as the name has been rearranged in recent times, shows vacuolization and characteristic changes in the basal ganglia and in the cortex. And this is a rapidly dementing disorder. You have somebody who may be at any age who over several weeks or months shows a very rapid progression. These are the findings that you're likely to see. The diffusion scan is very, very sensitive in CJD and very, very helpful. You're going to see also ADC deficits to go along with the diffusion restriction. And FLAIR and T2 scans are going to be very helpful. So what is CJD, or Creutzfeldt-Jakob disease? A rapidly progressive dementia. Usually patients don't survive 1 year. It's in 10 to 15%, it's an autosomal dominant inheritance seen in middle-aged and elderly individuals. This is the old classical CJD. And as I mentioned, the basal ganglia and cortices are involved, though you may also see this vascularization occur in the white matter as well. The diffusion-weighted sequence is the most sensitive. There are intracytoplasmic vacuoles, and it's a spongiform encephalopathy. A rapidly progressive atrophy will be seen if you get a chance to scan these patients again, which you're not likely to. And there are decreased metabolites generally, notably NAA. Now, something interesting happened. Back in 1986, the bovine form was described, BAC, or mad cow disease, and this was dubbed a new variant of CJD, and soon after that, it was described in humans. So this is the bad news. But for years before the human transmission of CJD, there's a condition known as Kuru, which has been prevalent in the cannibal populations of certain parts of the world. And CJD was transmitted, known to be a CJD type condition known as Kuru, is transmitted through the consumption of brains, infected brains. Let's move on to the vascular conditions that may be associated with dementia. The patient on your left is actually a normal control. The patient on your right has some mild memory impairment. They both have equal amount of cerebrovascular disease, microvascular disease. Now, you see this every day. It used to be called UBOs, unidentified bright objects. The term leukoariosis was proposed by a famous neuropathologist from Ontario. What is this microvascular disease, this leukoencephalopathy of aging? It's actually a demyelination that occurs around hyalinized arterioles, usually in association with a hypertensive type event. In other words, whether the patient is hypertensive or not, during the day or during some time of stress or whatever, there is an increase in the pressure. The hyalinized arterioles develop an edema around them. That edema around the arterioles demyelinates the white matter. So what you're actually seeing here is a demyelinating disease, even though I don't recommend that you call it demyelinating disease to avoid confusion with demyelinating disease due to things like multiple sclerosis. So this is a demyelinating hypertensive microvascular ischemia. Most people, I think, use terms like MVD or microvascular disease for short, and then there's no confusion. What are the features, and what is the distribution, and how do we distinguish this from things like multiple sclerosis? Well, you heard Dr. Grossman's tour de force on white matter disease this morning, so I may repeat certain things. The characteristic features of microvascular disease are confluent patchy T2 hyperintensities, which extend to but do not involve the arcuate fibers. They tend to spare the arcuate fibers, they tend to spare the corpus callosum. Involvement of the brainstem is fairly minimal. About the only kind of involvement you see is kind of patchy changes in the brainstem at the level of the pons, and that's about it. Demyelinating disease from things like multiple sclerosis loves the brainstem, loves the cerebellar peduncles, the cerebellum. Not so for microvascular disease. Also, demyelinating disease due to multiple sclerosis and other inflammatory conditions loves the corpus callosum, loves the arcuate fibers. All these areas are not involved by microvascular disease. Microvascular disease loves the basal ganglia. The basal ganglia tend to be spared by demyelinating disease due to things like multiple sclerosis. Though there is a gray matter component which is implicated in inflammatory demyelinating disease, we tend to see very little of that in cross-sectional imaging. So the microvascular disease itself is not a dementing disorder. You can have very severe microvascular changes and the patient can be perfectly intact. What what the patient exhibits is a loss of fine motor coordination, a prolonged reaction time. So when the patient goes from a little driving test that we give them to go from green light to red light, they're supposed to step on the brake. When the red light goes on, the people with white matter disease don't reach the brake as fast as people without white matter disease. So white matter disease itself is not demyelinating, but is not dementing. But what is dementing are the infarcts that may be associated with the white matter disease. Infarcts may occur without white matter disease. Multiple infarcts, especially bilateral infarcts, may be associated with so-called multiple infarct dementia, or MID. Now, I just want to stress again, we do not, as you well know, we do not image dementia. What we image at this point in time, though probably things will change in the future, what we image now is the structure that's associated with dementing disorders. What you see here are bilateral infarcts. Bilateral lesions of any kind, bilateral trauma, bilateral infarcts, bilateral tumors are very likely to cause dementia. Unilateral lesions are much less likely to cause dementia. So this is an example of multi-infarct dementia. What we describe is simply there are multiple infarcts. That's it. We can't say whether the patient is demented or not. What is Binswanger disease? Well, Binswanger described a rare, he only described a few patients who had this severe white matter disease with multiple infarcts and were demented. Now, probably he was just describing an example of multi-infarct dementia, but because of the characteristic subcortical involvement, this was back in 1984, it got its own name and it was dubbed Binswanger disease. We don't use the term much. I think multi-infarct dementia is adequate. Basically, we're just describing the infarcts anyway. It is the second most common cause of dementia. It occurs in something like 10 to 20% of cases over the age of 65 who have dementia, and it's associated with hypertension, strokes, and coronary disease. The characteristic in this kind of condition is the recurring neurologic deficits that occur in steps, whereas something like Alzheimer's disease is a slowly progressive condition. Now here's somebody that looks like they have severe hypertensive demyelinating microvascular disease with a bunch of strokes. There's holes in the brain, there's multiple cavities, lacuna-type infarcts. The white matter disease is very severe. There's sparing of the arcuate fibers. The corpus callosum is not involved. The brainstem shows minimal involvement, has, well, in terms of extent, it has severe involvement localized to the pons. There's lacunes in the pons. There's patchy changes. This patient is under the age of 60 and is not hypertensive, not diabetic. And this is an example of an autosomal interesting condition, which I think was mentioned to you this morning, which is known as CADASIL, or cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. Is this something you're going to see every day? Not necessarily, but you might get it on a quiz or something. So these are stroke-like episodes before the age of 60. It's caused by a mutation in the Notch3 gene. It's an autosomal dominant inheritance with 100% penetrance found in small blood vessels of cerebral and extracerebral blood vessels. In fact, the case I just showed you was diagnosed through a skin biopsy. So there's no brain biopsy required, unlike everything else that we see in the brain. The anterior temporal lobe are characteristically involved, the external capsule is frequently involved, and the frontal white matter. And it's dementing in only 28% of cases. Why? Because it's subcortical, and it's the cortical lesions that are more likely to be dementing in any of the processes that you're likely to see. Just a reminder that many of the white matter so-called abnormalities that you're seeing are nothing more than perivascular spaces. And you don't need a high-field scanner to see the perivascular spaces. This is a low-field scan, and this is a microfill injected brain in coronal plane. to show you the very rich vasculature, which of course you know is there, but which we kind of forget is there, because when we do an angiogram, we see a certain number of vessels. When we do an MRA, we see fewer vessels. So we tend to think that maybe there isn't much else there, and of course, there's a reminder that there's an extremely rich vascular tree that goes through the brain. And with high field units, like a 3T magnet, you're more likely to resolve the perivascular spaces. Now, what do you do with a patient like this? Well, these are perivascular spaces. Some of these may be lacunes. It's not possible really to make that distinction. Hydrocephalus has been called a treatable cause of dementia. The fact of the matter is that dementia is not really a characteristic of hydrocephalus, except when there's associated Alzheimer's disease or when the condition has been around so long that the brain begins to get damaged. MRI has really helped us in making a more accurate diagnosis of communicating hydrocephalus and communicating hydrocephalus in particular. I'm not going to talk to you about obstructive hydrocephalus, where you will see an obstruction generally. You'll see a tumor or aqueductal stenosis, but more about communicating hydrocephalus, especially idiopathic communicating hydrocephalus, which is an interesting condition that we see very commonly in the elderly population, more so than the younger population, though it can be seen just about at any age group. What is hydrocephalus? It's water in the brain, increased intracranial CSF due to a mechanical or functional obstruction to the CSF pathways. So in other words, all hydrocephalus is obstructive in some way or another. So the most correct way to describe it or to categorize it is it's either intraventricular obstructive hydrocephalus, if there's something actually physically obstructing, or extraventricular obstructive hydrocephalus. The extraventricular is what we call communicating hydrocephalus. Intraventricular is called obstructive. Now, obstructive and communicating have prevailed since the 20s. The original diagnosis was made if you had a hydrocephalic patient, the neurosurgeon would do a ventriculogram and would inject dye into the ventricular system, then do a spinal tap, and if the dye came out from the spinal tap, you knew you had communicating hydrocephalus. Now, the comparison of a typical atrophy patient on your left, or parenchymal volume loss, and a typical hydrocephalic patient on your right. What does the hydrocephalic patient show? Very big ventricles and sulci, which are either small or vary in size from small to very large. Notice that the typical aging patient or atrophy patient does not have very big ventricles. How does the sagittal view help? Well, MRI has been extremely helpful in this regard. In the typical atrophy patient, you see a kind of an undulating corpus callosum. In the hydrocephalus patient, you see a stretched corpus callosum. You see very tall ventricles. The ventricles get huge in hydrocephalus. They don't get huge in atrophy or aging. The big ventricles compress the roof of the third ventricle and they flatten it. They flatten the internal cerebral veins. There's downward pressure on the interpeduncular fossa, which becomes compressed. Notice the atrophy patient on your left. There's this gaping interpeduncular fossa, and on your right, there's a compression of the interpeduncular fossa. The transverse fissures I talked to you about, small in the typical hydrocephalic, big in the atrophy patient. Now here's an interesting phenomenon. This is a very old scan, but it's one of the best examples that I've come across. This is a dentist from New Jersey who had some cognitive impairment, a little memory loss. Debate was, is this hydrocephalus or is this atrophy? Well, he had very big ventricles, but he also had these very, very big fissures. So the debate was, are these fissures enlarged because of atrophy? And maybe he doesn't need a shunt because he's got bad atrophy. Anyway, the hydrocephalic hypothesis prevailed. The patient was shunted. The ventricles came way down. Now notice what happened to the Sylvian fissures. They also collapsed. So in hydrocephalus then, the fissures and the sulci may actually enlarge. And so when you shunt that patient, these fissures and sulci will collapse. If you do a sagittal view with T2 weighting, you take off the flow compensation, you get a very important component of the evaluation of hydrocephalus. You'll be able to see the signal, the flow void going through the aqueduct in hydrocephalus. You have a very brisk flow void. It goes all the way through the fourth, down the foramina of Luschka and Magendie, through the third, up the foramen of Monroe. In the atrophy patient, you don't get that kind of flow. You can actually measure it. The flow in cm per second will be increased. And if you do a phase contrast image, you can actually show the flow. You see the white, the brief white signal is the CSF going cephalad. The longer white segment is the CSF going caudal. There's a back and forth flow that occurs. And another use for the sagittal view is to look for a patent anterior third ventriculostomy. This is something you may encounter. It's a new surgical procedure. You can demonstrate the flow quite nicely. This is pre-op on your left, post-op on your right. And I thank you for your attention, and enjoy the rest of your day.